I'm Julian Patterson from Primary Care Commissioning, and we're going around the country to talk to practice-based commissioners and PCTs about their experiences and their success stories to see what we can learn about the future for GP-led commissioning.
I think the challenges for the organisational development are about knowing what it is you're expected to do. We've been sharing a 5-level commissioning model around in the Northwest, which says everything needs to be focused on a locality base, which it will be. You then need to consider your council coterminosity, because that's the secret for social care integration. You need to be well aware of the catchment areas of your acute trust. There may be one, there may be more than one. You need to be thinking sub-regionally about what you have to commission there, because that's where Tier 3 QIP savings will be made, and that still has to be delivered.
The organisational challenges we've got a limited company which delivers practice-based commissioning at the moment. That'll be replaced on the 1st of April 2013, pending agreement of the white paper. That leaves us with an issue around how we either close down an organisation or transfer its functions. And so there's some big challenges around HR for us as an organisation, but also for the primary care trust as well.
In practice-based commissioning, it was well recognised that there was a broad church approach to redesigning services, which included community staff, allied healthcare professionals, social care professionals. The term GP commissioning was delivered to focus the efforts of the referrer, but never meant to exclude other healthcare professionals. So we need to get that message loud and clear.
Well, I think each commissioning board are going to have different tools to use. We're going to have to be looking more at budgets, at referrals, you know, and we're going to need help with that. We're going to need help in resource-wise. We already have a very busy job to do, and this is going to be extra work for us to, you know, for us to take on board, which I see as an opportunity, you know, and I see it as a positive move. But we also are going to need that resource to be able to backfill when we need to do other things.
Clinical commissioning will probably be the easy bit, the bit that most of us are thinking about. Designing pathways, trying to set up contracts to deliver those pathways. The more difficult elements will be the roles that PCTs perform that don't necessarily fall naturally to GPs. There are hundreds of roles that PCTs fill at the moment.
It has been identified that PCTs currently carry out something in the order of 300 different functions. Now, some of these will pass to GP consortia, some will pass to the National Commissioning Board, and some will pass to the Health and Wellbeing Boards.
We in South Manchester have worked towards getting PCT staff much more practice-facing. So we now have a local team that supports us, and we would like to keep members of that team because they've established relationships with our practices and our GPs and practice managers. So there's that aspect that we want to hang on to.
So I think there's a big challenge to avoid reinventing PCTs. And I think part of the issue there is about hanging on to not just the individuals who have expertise and knowledge, some of which you could write down, but some of which is purely contained in their heads, but also hanging on to some of the approaches.
Of course, we know that we have to become much more productive and efficient, as well as improving quality through the QIP agenda. We have to generate savings of perhaps £20 billion nationally over the next few years. We believe here in Liverpool, and I believe as Chief Executive, the only way that's going to be achieved is through strong clinical involvement in shaping things and arriving at agreements and decisions.
We've got a time of considerable austerity, at a time when the PCTs, perhaps correctly, are being asked to reduce management costs. So, very difficult time.
In the past, what I do as a clinician in the consulting room is very much dissociated from the financial consequences. So when I write a prescription or do a referral, I'm essentially writing a blank cheque. And that's been the problem with PCTs. PCTs have been dissociated from the clinical world. So the finance contracting information is not linked in to the front line. So if you get clinicians together, primary, secondary, AHPs, talking about a pathway, you can often get agreement.
The added value of having GPs involved in commissioning is the work that they will do with their other clinical colleagues, both in the acute sector and between themselves, to design and implement new care pathways and different ways of doing things. They mustn't become commissioning managers we have people who can do that and who will support them on that.
I think that one of the key things is about the partnership between clinicians and managers, and also the ways in which PCTs and primary care clinicians have worked to change and improve things across the system. There's no point trying to solve a problem by just looking at one part of the system. You've got to look at all parts of the system to really make improvements and change. And I think PCTs have worked with practice-based commissioners and with other providers to make change happen in a collective way, and that's really important to maintain for the future.
One of the major roles that clinical commissioners can play being to help provide more joined-up care that is more understandable to patients and public, and that strips out what are often unnecessary or wasteful activities that have been provided in the past because somebody thinks they're a good thing. But actually, when you talk to patients and the public, they say, well, that's not actually the sort of care that we want to access, or that we find it easy to access.
A lot of GPs are very excited about what the white paper could possibly set up for us. We, on a daily basis, have frustrations in getting good care for our patients.
The hope is we will have general practitioners, and myself as a GP, to be the best GP I possibly can be and produce a practice that is the best a patient can get, my Gillette principle. But I think it's, for scale, something that every clinician needs to be involved in.
This new dispensation gives us GPs and other clinicians as well chance to actually redesign what's going on, redesign systems rather than just trying to deal with the daily grit and itch. So I think it's pretty quite exciting, and I think it has a lot of potential.
I have some caveats about giving a prognosis for GP commissioning, because I think it isn't a one-size-fits-all, one-size-fits-nobody approach. So you're going to find it working variously well in different places depending on what the topology is already, what the landscape is like now. In this case, I think we're in with a good chance. I think there's enough of the clinicians who are prepared to step forward and say, okay, I'll take that responsibility and I will do my best to discharge it. I think there's enough GPs who've got entrepreneurial spirit to be able actually to say, it's not about making money for myself, it's about making the best I can for the patients.
Well, sometimes we've struggled to define exactly what we mean by commissioning at scale. And for GP commissioning, this is about the scale of every single consultation in every practice, in every surgery, in every clinic in England that needs to become more efficient. And what brought that home to me was my wife, who sometimes annoyingly switches the tap off whilst I'm cleaning my teeth. She says, I'm wasting water. But when I pointed out it was such a small amount, she said, well, if that small amount on a weekly, yearly basis can get up to many hundreds of gallons, and if 50 million people in the country had the attitude that you had, you could be wasting 10 billion gallons of water. So your attitude, James, is wasting a huge amount. And that started to me think, well, if we do remarkable things at small scale on a regular basis in practice, aggregating up could make huge efficiency gains.
We are almost sort of, stainless steel rats in the system. We will find a way of making this work. We have done it in the past, we will do it in the future. So on the basis of my colleagues' perseverance and ability to innovate and change with what's required of them, I'm cautiously optimistic.